Hey everyone, today we are tackling a massive topic, one that you'll see on your exams and definitely in your clinical practice: metabolic acidosis. We're going to break this down step by step and build a complete study guide to help you really truly master this. Ready? Let's jump in.
So, before we get into the nitty-gritty, I've got a little clinical puzzle for you. What's the one thing that links a patient in DKA, someone else with severe diarrhea, and this very specific breathing pattern? I mean, deep, fast breaths. Yep, you guessed it. It's metabolic acidosis. And by the time we're done here, you'll know exactly how all those pieces fit together. So here's our game plan. We're going to use what I like to call the pyramid of mastery. We'll start at the bottom, with the core problem itself. Then, we'll build up to the causes and how the body tries to fight back. From there, we'll get into what it looks like in a real patient, and finally, we'll hit the top of the pyramid, your nursing priorities and everything you need to know for the NCLEX.
All right, first things first, we have to build a solid foundation. You can't treat what you don't understand, right? So let's start with a super player definition of what we're actually talking about.
Okay, the key thing to get here is that this is a two-way street. The problem happens for one of two reasons. Either the body is making way too much acid, or it's losing its main base, which is bicarbonate. Think of bicarbonate as your body's own little fire department, putting out all the little acid fires. Well, in metabolic acidosis, either the fire is just way too big for them to handle, or you've literally lost your firefighters. Either way, the result is the same. The blood pH plummets and things get dangerously acidic. Let's just look at this side by side. On the left, you've got a happy, balanced system. The pH is right in that sweet spot between 7.35 and 7.45, and bicarbonate is doing its job. But on the right, that's the danger zone. The pH has dropped below 7.35 because that whole bicarbonate buffer system has either been totally wiped out or just completely overwhelmed. Okay, so we know what it is. The next big question is why? Why does this happen? And maybe more importantly, what does the body do to try and fix it? Understanding the causes and the body's backup systems is absolutely critical. You can pretty much sort all the causes into two main buckets. In the first bucket, you have acid accumulation. The number one example you have to know for your exams is DKA, diabetic ketoacidosis, where the body is just churning out these keto acids. Sepsis and kidney failure also fall in here. Then, in the second bucket, you have bicarbonate loss. And the classic cause here, severe diarrhea. All that fluid from the lower GI tract is packed with bicarbonate, so when you lose a lot of it, you're literally flushing your body's buffer away. So this whole thing really unfolds like a chain reaction. It all starts with that initial problem, too much acid or not enough base. That makes the pH drop, and the body's alarm bells start ringing. The first responders on the scene, the lungs. They kick into high gear, making the person breathe faster and deeper to blow off carbon dioxide, which is an acid. Then the kidneys, which are slower but way more powerful, they jump in to help by kicking out acid and holding on to bicarb. But if all that fails, the body just can't keep up, and that acidic state starts to cause serious damage to organs.
I love this little quote. It's such a great way to remember how the kidneys and lungs work together here. Think about it. In something like renal failure, the kidneys are the source of the whole mess. But it's the lungs that jump in immediately, trying to provide a quick fix by changing the breathing rate. It's just a simple, powerful way to remember that whole interaction.
We've covered the what and why. Now let's get super practical. How are you going to spot this at the bedside? What are the key signs, and of course, the lab results that are going to scream metabolic acidosis?
Let's start with the big one, the most classic sign, Kussmaul respirations. This isn't just breathing fast. It's this deep, rapid, almost desperate-looking breathing. And it's not a lung problem. It's the lungs trying to save the day by blowing off all that extra CO2. You see it classically in DKA. But beyond the breathing, you're going to see other things, like low blood pressure and a fast heart rate. And as the brain gets affected by the acid, you'll see confusion or even a decreased level of consciousness.
But the real proof is in the pudding. And in this case, the pudding is the arterial blood gas, the ABG. Now, early on, in an uncompensated state, you'll see a low pH and a low bicarbonate, but the CO2 might still look normal. But once the body starts to compensate, things change. The pH and bicarb are still low, but look, now the PaCO2 is also low. And that right there, that's the proof that those Kussmaul respirations are working. The lungs are successfully blowing off that acidic CO2.
Okay, if interpreting ABGs makes your head spin, this mnemonic is about to become your new best friend. It's ROME, respiratory opposite, metabolic equal. For what we're talking about today, just focus on that second part.
In metabolic conditions, the pH and the bicarb move in an equal direction. So for metabolic acidosis, what do you see? They're both down. The pH is down and the bicarb is down. See? Simple as that. All right, here's a tool that's a little more advanced, but the NCLEX loves to ask about it, the anion gap. Now, don't get intimidated by the math. Its purpose is actually really simple. It's a detective tool that helps us figure out why the patient is in metabolic acidosis. It helps us figure out if we're dealing with one of those acid accumulation problems or one of those bicarbonate loss problems. And here's why calculating that gap is so worth it. If the anion gap is high, we're talking greater than 12, that's a huge clue. It tells you there's a bunch of extra, unmeasured acids floating around in the blood. This points you right to causes like DKA or the lactic acid from sepsis. But if the anion gap is normal, it tells you the problem isn't extra acid, it's a loss of bicarb. And that points you straight to a cause like severe diarrhea. It's an incredibly powerful diagnostic clue. Okay, so you've nailed the diagnosis, you know what's going on. Now, what are you going to do about it? This section is all about your role as the nurse, the absolutely critical assessments and interventions you need to be doing. As the nurse, you've got to have eyes everywhere. You're watching their breathing. Are they starting to get tired from all that work of Kussmaul breathing? You're constantly assessing their neurostatus. And this is a huge one. You have to monitor their potassium. In an acidic state, potassium moves out of the cells into the blood, which puts the patient at a massive risk for hyperkalemia and deadly heart arrhythmias. You have to see that coming. And this is probably the most important thing to remember about treatment. This is the golden rule. You can't just throw some sodium bicarb at the patient to make the pH number look pretty on the lab results. It doesn't work that way. If the cause is DKA, they need insulin. If it's sepsis, they need antibiotics. If you don't fix the root problem, the acidosis is just going to keep coming right back. All right, we have built our pyramid of knowledge. Now it's time to stand at the very top and boil it all down to the high-yield facts you absolutely have to know walking into your exam. This is the final cram session. Let's do a rapid-fire review of the must-know exam pearls. 1. Kussmaul breathing is the lungs trying to compensate. 2. DKA and diarrhea are your poster children for causes. 3. The classic ABG shows a low pH and a low bicarb. And 4. A high anion gap means the body is adding acid. If you can nail these 4 points, you are in fantastic shape for the NCLEX. And here are just a few little one-liners to help lock these ideas in your brain. Low bicarb equals metabolic acidosis. It's simple and it's true. DKA blows off CO2. That connects the disease right to the Kussmaul breathing. And deep breaths fix body acids is just a great little reminder of what the lungs are trying to do. All right, time for a pop quiz. Let's apply what we've learned. You've got a patient with DKA, and these are their ABG values. Take a second, use your Rome mnemonic. How would you interpret this? And the answer is B, compensated metabolic acidosis. So let's walk through it. The pH is low and the bicarb is low. They're moving in an equal direction, so that tells us it's a metabolic problem. Since the pH is low, it's acidosis. Now we look at the PaCO2, it's also low. That tells us the lungs are working hard, blowing off acid to help out. And that, my friends, is compensation in action. Okay, let's wrap up with one final scenario that's all about clinical judgment. You walk into your septic patient's room and you immediately spot it. That classic, deep, rapid Kussmaul breathing. You know this isn't a lung problem. It's the body's fire alarm going off for a severe acidic state, probably lactic acidosis from the sepsis. So what's your priority? What do you do first? Think about your assessments, who you call, what you prepare for. That kind of critical thinking, that's what makes you a great nurse.